I appreciate the opportunity to be here today. So thank you, Tim, for the kind introduction. Marin, thank you so much for being here with me as well. This is an amazing opportunity. My mom used to tell me there are two words that we don't often use in the English language enough, and those two words are thank you. And so again, thank you all for letting me be here. Thank you for having us here. Thank you to all of our healthcare workers. I mean, I was deployed, as Tim mentioned, for an entire year through 2020. And so I saw COVID from sort of a retrospective look where I had got a chance to see what we did here. And I cannot tell you how amazed I was every single day at each and every one of the healthcare workers and persons that just took care of us to put us where we are now. We would not be where we are in this fight for COVID had it not been for the work that you've done. So thank you so much for doing that. It's Marty.
Well, I'm excited to be here too. I've known Stephen and gotten a chance to work with him over the years, but we've never really done a gig like this. So I'm looking forward to working with you and you, Stephen, today.
Going to be great. You know, I'll tell you, you got the clicker?
Yep. Oh, gosh.
So, all right, let's see how tech challenged I am. So first we're going to go through the agenda. So in the Air Force, and I'm an Air Force officer, as Tim said, we like to tell you what we're going to tell you, then we tell you, and then end up by telling you what we told you. So here's our agenda.
And then we're going to show you what we told you.
Show you what we told you. But I like to start things with a little bit of a coffee break because it's early in the morning. And the reason I do that is because I think about something that a senior leader once posed to me, a question they posed to me. They said, is it mission first, people always, or people first, mission always? And I said, well, I'm a people person. I think it's people first. If you take care of the people, they'll take care of the mission. And that leader told me, no, it's more like mission first, because the mission is what drives us together. That's what pulls us into this fight together. And it made me think about something. And the reason I do that as a setup, as a backdrop to this coffee break, is more so because it's the mission that we're going to go through, what we're talking about. This video I'm going to show, that coffee break, ties us back to the mission, ties us back to why we're here. So we'll do that. So that little boy, that's my son. That's my son, Stephen Coffey II. I call him Deuce. And the thing about that story, it always takes me back to a very vulnerable and special time. And I use that, again, just to center us on why we're here. You know, at MedStar Health, they have these safety stories before every single thing. We pause and we look at those stories and we figure out, what are we here for? What are we doing? So I'll give you a little bit about me. My wife and I were married 2011. The only thing that's constant in the military is change. So we ended up moving from Tampa, Florida up to Hampton, Virginia. And then my son, Stephen, decides to leave his fully furnished luxury penthouse suite and be born on September 28th, 2012. And what his birth was very natural and normal for us, or so we thought. When he was born, he had a low glucose and a high bilirubin, and it was a little bit of cause of concern, but not something that I knew much about. I'm not a doctor, I'm an officer. And so the thing that surprised me is that when we started to notice things that were wrong and started to notice things that were awry, and we addressed those concerns to doctors at the military treatment facility, our concerns were dismissed. Maybe because I wasn't a doctor. Maybe because I was wearing a sweatshirt and a hoodie going into the ED on the night before Thanksgiving. Maybe because I didn't use the right words to express what was going on with my son. And then on November 28th, we're sitting in Georgetown University Hospital, and I had a resident who was presenting my son to a more senior doctor, said, "This is Stephen, our 2-month-old from an outside hospital. His fulminant liver failure, secondary to galactosemia." What I didn't know was those signs and symptoms I saw when he was born of having low glucose, high bilirubin, those are classic signs of galactosemia. There was a misdiagnosis and a delay in diagnosis at that hospital. When I brought up concerns, I wasn't heard. I wasn't seen as a partner in his care. Those are the things that really triggered me to say, something's wrong here. And one thing that happened on December the 5th, so my son's liver transplant anniversary is actually Sunday. He had his transplant. 5 days later, had a transplant. And so the thing that struck me, how did I get into this patient journey of quality and safety? How did I find this new passion? Because I often say that when your avocation, what you love to do, and your vocation, what you're paid to do, when those things intersect, you find your passion, you find your why. And I found that why following the transplant, as MedStar Georgetown said, we're going to start this new patient and family advisory council for quality and safety. We're going to look at quality and safety and improve those things for our patient populations because we want to drive harm down to zero. And I'll tell you, the one event that really triggered that was circled around milk. So the biggest project we addressed at our PFAC was about food nutrition. And oftentimes in the hospital, the only choice that a patient has is what they can eat. I can't tell you when I want to get labs. I can't tell you when I want to have a procedure. I can't tell you to stop the beeping from this machine, but I can tell you what I want to eat. And my son needed to have his milk fortified, soy milk fortified. And what we found out was that there was no mechanism that was in place that would allow for me to go off to a grocery store and pick up a can of soy milk and bring it back into the hospital because it has to be billed, it has to go through materials, it has to be approved. And I'm thinking to myself, this is insane. The doctors are telling me that I need to fortify this milk to make it more calorically dense so that he can get better, he can have food and nutrition, the cornerstone of getting better, and you don't have a mechanism. When that problem arose and this group just happened to collide at the same time, we started a PFAC. And I think Marty's going to come tell you a little bit more of how we got there.
Thanks, Stephen. So yeah, I did go to Boston College Law School here, and I have a background in litigation, defense litigation, a big Chicago law firm. I then went to the American Medical Association and did government affairs there. I ran the Tort Reform Coalition there for about 12 years. So I joke that in my career, when I came to a fork in the road, I took it. And somehow I ended up as working with the World Health Organization in 2003 to build a patient and family network of advocates that were going to join its World Alliance for Patient Safety around the world and be that accelerating voice of the patient, working with their governments and their ministers and their other stakeholders to try to improve patient safety around the world. So I did a bunch of workshops around the world, really looking for people who'd had bad experiences or unexpected outcomes who were willing to come and work with other people to try to make things better. And it was a really exciting thing. I did, just to give you a sense of it, one of the workshops I facilitated in Perth, about a third of the audience was Aborigines. There was people who came there from the bush sometimes to talk about what it was like to get care in their healthcare system. It said a lot about the courage of the Australian leaders to bring people who were not used to even sitting in a conference room to talk to us about what their experience was like. So it was a very rich experience. And then I ended up back in the United States working with MedStar. And MedStar had the VP of Patient Safety and Quality. His name is Dave Mayer. He was a colleague of Tim's and mine back in Chicago. He'd come from Chicago. We'd worked a lot with Tim in developing what became Candor, the 7 pillars, and Dave wanted to put their HRO journey on steroids. So this was the model for their HRO journey. They hired HPI to do the work. My job was to build out patient and family advisory councils in all 10 MedStar hospitals and in their ambulatory care centers. 2 of the hospitals that really, there's 10 hospitals there. And HPI, by the way, had one slide in their slide deck about working with patients. And it said, what do patients want? That was the title. And it was, don't harm me, tell me the truth, and be nice to me. That was the slide. Nothing about listening, nothing about engaging us, nothing about understanding what our priorities were or what they could learn from us. So it was a really, I guess, empty palette for us to work on. There were 2 hospitals in the MedStar system that really stood up and said, you know what, we don't want to do this in a lukewarm way. We want to do this in a robust way. One of them was Georgetown. I met Stephen through Georgetown. Their leader was Lisa Boyle. She was a surgeon. We went there for a first meeting, think we were going to meet with her and explain to her what we were doing. She walked us into a room with 60 people. It was the leadership of the hospital. She said, this is really important to us. I actually evac'd my husband on a helicopter from a MedStar hospital when they were killing him. This is personal to me. We're going to make a big deal of this. The other one was MedStar Franklin Square in Baltimore. CEO there said, I was at a hospital once that had a patient and family advisory council. They helped us pick out menus. They helped us pick out the art on the walls. I don't want that anymore. I want you to find me the critics, the people who haven't had good experiences here, and I want you to find me the people that are really networked in their community so that when they leave here, they say, this is a hospital that tells us the truth and cares about safety, and they go out and they talk to their communities about that. So we had that kind of leadership, and out of that came kind of our special sauce, and that was a patient and family advisory council that is focused on quality and safety. So that's in the charter. That's all we care about. We don't care about anything else. We work on quality and safety. The membership is half people who identify primarily as patients or family members, and the other half are healthcare workers. And it's not the people who have patient safety in their titles. We said, open this PFAC up to your frontline workers, to your coders, to your transporters, to your janitors, to the people that are passionate about safety in your organization or just want to see your organization be the best that it can be, because they probably have family members that work here too. And we just knew from our work at WHO that when you pull together frontline people and you pull together patients and families, it's like an empathy engine. I mean, the magic happens. People start listening to one another. They start connecting. We had workers telling us, and really thinking about the worker safety framing that we had this morning. We had workers say, I love this committee because I get to talk about things here that I can't mention when I'm on the job. So that was our special sauce. And then at Franklin Square, the CEO said, I want this organization to report to the board, and I want to have a board member on it. So that was the last part of our special sauce, is let's make sure that we have a high connectivity to the leadership of the organization, the governance of the organization, to make sure that what comes out of the mouths of people like Stephen actually gets to the board. You want to jump in?
So one thing that is so critical about the PFACs, and this is one of the things that separates the Georgetown PFAC from a lot of the PFACs I've seen across the country, is that they have students. So if you're in a teaching hospital, you have such a rich body, a repository of people that could be part of your PFAC and bring a perspective that's oftentimes forgotten. It's oftentimes forgotten and lost because you're now not a student, you're not a resident. We have nursing students, we have graduate students, and those things are such an important part of why the PFAC, as Marty said, is well-rounded, that we have everyone's perspective in. It's one of the things that Dr. Mayer always says. Dave says you have to train the young and educate the young and regulate the old.
Yeah.
Educate the young, regulate the old, and that's what we do.
I don't know how many of you have actually gone through a gap analysis of Tim McDonald, but it's a special time if you get a chance to do it. But he brings out the same kind of energy from the frontline workers that he involves in the gap analysis. So a lot of people that care a lot about safety and quality. It's very personal to a lot of us, and we get that energy in these PFACs. Stephen, I'm going to move us along because we're on like slide 2. And so we did the MedStar 10 hospitals at the same time, or roughly the same time. The Affordable Care Act was being rolled out in the United States. Lots of resources there. It was an Affordable Care Act that funded a lot of the final work on Candor that Tim led, was the architect of, but they also put out this collaborative on steroids, this very Berwickian kind of save 1,000 lives, except this was get every hospital involved in reducing 10 hacks and 30-day readmissions. And then they funded networks to coach them. One of the biggest networks was Vizient. And they hired us to build patient and family advisory councils using the MedStar model, quality and safety, reporting to the board, workers, members of the council in about 100 hospitals across the country. So we had a really nice sample here. In 2018, CMS gave us more money to look back and go find the hospitals that are doing really well with this, that are doing well on performance, good on our outcomes, but also really robust in the person and family engagement work that you've been doing. And let's look at them. So we visited 10 hospitals in 2018, and there was just a wonderful assortment that kind of came up out of our survey database of doing really interesting work. Cheyenne Regional Center, just to give you a sense of it, is in Cheyenne, Wyoming. It's a public hospital. Quarterly, they do what they call a listening session, and they invite a family or a patient that's had a bad outcome to come into the hospital. And it's mandatory attendance for every person in that hospital who touched that patient or family as they went through the journey at the hospital. And they can't talk, they can just listen. So it's not about being right, they just have to listen. And when we would tour that hospital, people would stop us and say, have you heard about our listening sessions? Because it was such a profound experience for them. They said it was really, really hard, but it helped them understand what happened to a patient after they left the ED and were discharged to the ICU. They would lose track of that patient. They wouldn't know that they'd done something in the ED that had harmed them or helped them or whatever. So it was just that kind of innovation. Emory University, the head of their PFAC, is a man probably in about his 50s. His name is Stephen Faust. He's a hemophiliac. You cannot say no to Stephen Faust. I mean, he has really, really generated a lot of work around their infection, and their infection rates are great. Medical University of South Carolina hired the mother of a frequent user, a person like Stephen, a parent like Stephen, and she is just relentless. Carolyn DeLongchamps. I think there might be people from MUSC here today, but she was just a fantastic person who was building relationships across that organization. UCLA had a Spanish-speaking PFAC, and one of the members saw a transgender person being disrespected when he was visiting his son who was hospitalized, and he brought it to the PFAC, and he saw staff actually making fun of this person as well as other people. And it ended up with a program to really raise the sensitivity around the transgender workforce that came out of a PFAC that was Spanish speaking because of one person's experience. So it was those kinds of stories that we found. This is what we really learned from that experience, that you have to have this as a strategic priority of your board. You've got to embed your people in your patient safety work, and then you've got to be open to the innovation that they bring to the table. And this is our logic model. And this really, I think, I'm sharing it with you because I think it really is instructive for how we need to be looking at and researching the role of patient and family engagement in quality and safety going forward. Every hospital, the little circle up there, has their priorities. The purple box is what they build out to achieve it. They have a patient safety program or a quality and safety program with a budget, with metrics, with staff. The gray boxes were the patient and family engagement pieces that we brought to it. And there were 5 metrics that we used, one of which was, do you have a patient or family member on your board? Do you have a PFAC? Do you have a staff person who's responsible for the PFAC? And then we looked at whether you have that mix, if you actually make your outcomes better and make them better faster. And we found with falls, yes, with 30-day readmissions, yes, that's what we studied. There's going to be a lot of other work that I think is actually already following this to look at pressure ulcers and other things. But the aha moment for us here was, you don't look at patient and family engagement in isolation. It's part of a bundle. And when you're seeing it happen robustly, you're probably seeing leadership in that organization. You're probably seeing an organization that really is walking the talk of learning from their patients and learning with their patients. And so that's the way I think we're hoping to shape the research about this going forward. Because if you try to isolate patient and family engagement and tie it to outcomes, you just don't get a good methodology. Okay, Stephen, back to you. We're going to do a little bit about safety and equity. The last set of PFACs we built, I'm going to set this up a little bit for you, was at the University of New Mexico. They hired us right before COVID. We ended up doing that virtually, and we were able to implement PFACs across their system faster because people were working from home and they had time in their hands. So we turned that all into a virtual product that we're now marketing with Vizient. And Stephen is, we interviewed Stephen as part of it, and I want to share that film here with you to kind of set up Stephen's next talk. So if we can roll the film, that'd be great.
Hello and welcome. My name is Armando Nahum. I'm a patient safety advocate and a principal at H2PI, the Healthcare and Patient Partnership Institute. Joining me today is Lieutenant Colonel Stephen Coffey. Hi, Stephen. If you don't mind, would you be so kind to introduce yourself and your role at MedStar Georgetown University Hospital Patient and Family Advisory Council for Quality and Safety?
Hi, thanks Armando. I am, as you said, Lieutenant Colonel Stephen Coffey. I'm an Air Force officer, a patient advocate, and member of the MedStar Georgetown PFAC for Quality and Safety. So I've been there since 2014.
Thank you, Stephen. When a hospital or healthcare system has an active PFAC, we see them engaging the PFAC in projects that are strategic priorities. The MedStar Health Sepsis Prevention Initiative that you contributed to is a good example of that. What about the other way around? Projects that the council sees as important and brings to the organization? Have you seen this happen?
Absolutely. You know, one of the things that drove me to become a member of MedStar PFAC was the fact that my son, Stephen, who had a liver transplant at a very tender age of 8 weeks old. He had a transplant due to a metabolic condition called galactosemia. And this condition doesn't allow his body to break down the simple sugar galactose that's found in human and animal milk. So when we were in the hospital, immediately following his transplant, one of his providers said that he needed to have his soy milk calorically dense. And so what that meant was to add some powdered soy milk to his formula so he could gain more weight while in the hospital. And I thought it was just as simple as being able to run down to the big grocery store to pick up a can of soy milk and bring it back to the hospital. But I was told that I couldn't do that, that thing had to be sent through materials. It had to get through billing. It had to be through management. And it was on a weekend, of course, when all the things that fall apart in the hospital, they always happen on the weekend. And so I realized then that there was a gap in care. And so when we started our PFAC in 2014, one of the first projects we worked on, and we brought this to MedStar Georgetown as an organization, was to look at our dietary. How could we fix that gap that's seen in care where we could provide nutrition to patients? So when you think about how it is that patients are oftentimes able, and the PFACs are oftentimes able to bring issues to the hospital, it's something that requires a listening to our voice. You know, one of the things we've worked on at MedStar Georgetown's PFAC is opioids. I mean, that's an issue that some of our community members who've been impacted by family members and friends that have had opioid concerns and issues, we brought that to the PFAC and said, hey, this is something we need to look at, maybe medication reconciliation, and brought it to our PFAC for MedStar Georgetown to take a look at. The other things, and this is something that's very near and dear to my heart as a minority, you know, I think the world and certainly our country had an awakening with George Floyd, what that happened this summer. And our PFAC saw that we needed to look at diversity and inclusion. We needed to look at some of these unconscious biases that occur. And so we brought that issue of looking at diversity and inclusion to our PFAC to have that as an issue that we raised amongst the hospital. And what was really great about this is that they've taken that and said, you know what, it may not be a physical medical issue or concern, but it is certainly a concern that we need to address and to talk about because it impacts physical medicine and how we deliver care to our patient population. And so one of the things we've done at MedStar Georgetown was to start these hot topics, if you will. And we've recently had one where we talked about diversity and inclusion. We look at the COVID crisis that's going on now. This pandemic has a severe impact in mental health. And another one of those topics that we brought to our PFAC, to our leadership, was to say, hey, we need to look at how mental health is impacted because of COVID, not only from the patient perspective, but also from a provider perspective. So I think when organizations and hospitals partner with their PFACs and really value their voice, big changes can happen.
That's absolutely excellent, Stephen. I really enjoy talking to you today, and I can't thank you enough for giving us your time. We know how busy you are. So thank you so much for all of that. We really appreciate it.
No, I really appreciate this opportunity to speak with you guys, and wish you the best.
Yeah. So, you know, I think that video says a lot about how the power of patients and how the power of PFACs bringing up issues. And another one that we had addressed at Georgetown was sepsis. And so I think we'll just go to this next video here.
We want to give you a sense of what it is that PFACs actually bring to the table. And one of the big accomplishments at MedStar is a sepsis program that really produced outcomes. And Stephen was in the middle of that. So you're going to see Stephen a little bit more here too. Let's go.
Live with two words, if only. every day. And they play a big role in my life, because if only I had been more educated, if only I knew about sepsis, maybe my son would be alive today.
In spite of having sepsis, and he had it at such a young age, my son is just as normal as any other kid. He's riding his bike or learning how to ride a bike with training wheels. He's playing basketball. He wants to get into t-ball. So those things that normal 4-year-old kids do, he can now do.
Josh was very fit, he was healthy. He had done over 1,000 jumps skydiving, and he had become an instructor. So he was very healthy. On Labor Day weekend of 2006, Josh was on his last jump, and there was a cold air density problem that pushed his chute inward and threw him to the ground at 60 miles an hour. Joshua jackknifed. He broke his left femur, and his helmet produced a contusion in the back of his head. He was immediately taken to the emergency department, and upon arrival, his brain started to swell. Josh acquired not one, but 2 cases of MRSA. He battled and won those. And then he acquired what they call delirium or ICU psychosis. But he won it. He was strong. He fought all of it. And then finally, the doctors came to us one day after 6 weeks in ICU, and they said, Mom and Dad, it's time to go home. Josh is doing well. 6 days into rehab, we received what we called the phone call from hell, 11:30 at night, from his neurosurgeon, saying that at rehab, Josh spiked a fever of 103, and he coded.
Stephen is a special little boy, a really special kid. And I know every parent thinks that their child is the most special, but Stephen's really special because he had a liver transplant when he was 2 months old. One of the things that we learn as transplant parents is that we're kind of frequent flyers, if you will, for hospital visits. It's not a frequent flyer club you want to be a part of, but it's also a club that makes you very aware of things. So it's just he and I, just the boys, we're at home, and things are going great. At first, he was lethargic. He slept a lot more than he normally would sleep during the day. The other thing is that he was shivering and he had a fever. And then the fact that he was just throwing up and he was restless all through the night. Those are the things that kind of tipped me off that something was really, really awry and let me know that this might be sepsis. As a member of the armed forces, we have this thing that we say, when you see something, say something. It goes beyond just Homeland Security and national defense. It applies to your healthcare. When you see something, say something.
Josh died of sepsis.
My son survived sepsis. And I think because I took him in when I did, it was the biggest factor in him surviving.
Go to the emergency department. It's the only place that they're equipped to handle sepsis. We have documented cases now where a patient would come in through the emergency department and not say much except, I feel feverish, could be the flu. And so the patient sits there, and you know how busy emergency departments are. That person is not really dying at that moment that they walked in, and so it's not a priority. They don't have a gunshot. So 3-4 hours go by, and that's how fast sepsis works. That 3-4 hours gone by the time that person gets seen, they're now passing out, and they're now in septic shock, and they're now dying. Learn the symptoms. Learn about sepsis today.
Shivering, fever, or very cold.
Extreme pain or general discomfort.
Pale or discolored skin.
Sleepy, difficult to rouse, confused.
I feel like I might die.
Short of breath. Even if you think you have the flu, if you have an infection, you're running a fever, you have any of the symptoms, say the words, I suspect sepsis. I think this might be sepsis. If the person suggests that it might be sepsis, that means they need to be seen right away. Sepsis is extremely treatable, but you have to catch it early. Call 911 immediately. Do not waste one single minute. And when you get there, say the words, "I suspect sepsis."
We wanted to show you that because that was produced by a collaboration between the safety and quality people at MedStar and the PFACs. And we had, by this point in time, 10 PFACs up and going in all the hospitals. We actually asked them to compete to see who could get the word out to their communities faster with educational materials, including this video, to really raise awareness amongst the public about the importance of getting quick treatment when you feel these symptoms that could be something else. So just to give you a sense of once you build the infrastructure, once you get that structure in place, the magic that can happen. We have a little bit of time left, and before we leave this, we're going to go through this fast. So we are also, Stephen and I are now friends and colleagues, and we're looking back, like everyone is looking back at the 20 years of work on patient safety that many of you have been doing here, and wondering why we haven't made enough progress. And so is the World Health Organization. The World Health Organization renewed its commitment to safety in May of this year with the publication of a Global Patient Safety Action Plan. I think people from RLDatix were involved in shaping that plan. But that network that we started building 10 years ago never really got built in the United States. So Stephen and I and a group of other people are gonna basically step up and try to get more attention paid, especially from our government leaders here, but also from stakeholder partners like you, to really see what we can do in the next 10 years, because we haven't made enough progress in the last 10 years. This came out of an extraordinary conversation we had in Idaho in May, where we just looked at ourselves and wondered, have we traded our power for a seat at the table? Because we've been good partners. We've been trying to work with the healthcare system sort of in their structures and in their framing, but anesthesia is safer. There's not much else that we can demonstrably point to as safer, and our government, frankly, just hasn't done enough. At dinner last night, we were talking a little bit about the data that government collects about safety and quality, and it's bad data. I mean, we don't really even know where our problems are in the United States, despite all of the regulation and all the reporting that you guys are asked to do all the time. So here's our group. I know you might recognize some of them. Beth Daly Allam here in the corner is the granddaughter of a mayor of Chicago. She lost a child at Northwestern. She's very, very involved in children's safety. So for those of you from Children's Hospitals, I think she's on the board of SPS, Solutions for Patient Safety. Stephen Margot Burrows made the film Bleed Out. If you haven't seen that yet, pour yourself a glass of wine and take a look at it. It's on HBO, but it's the journey of them through litigation after the unbelievably bad care that their mother received. So that's our group. There's more. We're joining this network. There's 300 patient safety champions who was anointed over the last 10 years. We're going to really expand that in the United States. Tim, you're going to meet Stephanie Newell. So in that center picture, she's not Sue Sheridan, but the other blonde. She's in Australia. You're going to be working with her soon. We're going to build on this network. This network is much, much bigger than what you've got here, but this just gives you a sense of the workshops. This is the Global Patient Safety Action Plan that WHO put out there. They see that there's 4 big stakeholder groups that have to be engaged. One of them is government. One of them is facilities. There's also WHO itself. They're going to actually track progress for the next 10 years, doing a report card every 2 years. So they've got a 10-year plan. And then other stakeholders include patients and families, educators, people who make products, people who deliver services. It's a big group. But we each have our own strategy. So there's a patient and family engagement strategy, one of 7, that involves candor. It involves building PFACs. There's also strategy 6, which is really about integrating data. It's all the things that you guys are doing. This is a space where you guys can lead, and we want to partner with you if you see that as an attractive option. But it's looking at the ways in which we track our data in our facilities and then use that data in a way to improve safety. I wanted to show this slide to you. It's a little busy. Oh no, we're missing it. Oh, here's the organizations that we're talking to already. The blue boxes are people that we already have established some kind of partnership with. We've had extraordinary conversations with CDC, CMS, Joint Commission, Lucian Leap Institute. Actually, Joint Commission is pending. The yellow boxes are pending. Joint Commission has a new CEO coming in January. We're going to meet with Jonathan Perlin when he arrives. Stephen has just teed up a conversation with the patient safety people at DoD. We've got phone calls happening with ONC. Armando Nahum, who you saw as the other dad in the sepsis video, is, as we speak, making a presentation to the Secretary of Health and Human Services because he's on a task force looking at antimicrobial resistance, and he's making a talk right now as we talk to you. So that's what we're up to. We would love to see RLDatix as a partner here. This is the strategy where you just like fit like a glove. I mean, there's sub-strategies there, but it's getting reporting systems up and going in hospitals. It's using the data that you get from reporting systems. It's using your other databases that you can integrate to get past those clicks that we now are stuck with. And the metric is looking at hospitals that actually have electronic reporting systems for medical error over the next 10 years. There's a whole system of milestones and metrics that WHO is going to be looking at in their report cards. So we want to give you that sense of where your work, the work that you're doing, plugs into everything that is happening with the network that we're going to be trying to amplify. Here's some resources. The sepsis work that Armando and Stephen did at MedStar. The lead programmer for that was Dr. Meena Seshamani, who's now the head of Medicare. That's an article in the middle that she published with these fine people. Some other resources about the work group done in PFAC, so we're happy to share with you whenever. And we might have a little bit of time left for Q&A. Stephen, I feel like I took over the end of this, but do you have comments you want to make because you're part of this network
No,
too?
you know, but we got questions. I want to do the questions. Those are always fun. Yes.
Okay. Thanks very much for giving us some time today.
Quick question. Thank you both. This is unbelievably moving and deeply personal, right? How do our broader RLDatix customers, how do they engage and participate with this type of an organization? What is the 1, 2, or 3 steps that you could say? If you want to know more, if you want to get engaged, if you want to do something more locally, tell us how our customers, how our clients could engage more with something.
We've got a number of different ways in which, if you're interested in building patient and family advisory councils that are built, that are focused on quality and safety, we give away all of our tools for free. So you can just go to our website and download those tools. We also have an online sort of coaching product that you can do either as an organization or as a collaborative, and that's affordably priced, so we can deliver that to you. On the network, on so this is a shift now to this network of patient advocates that are going to be working with WHO. We have a couple of different ways to partner. One is that we can partner with an organization like RLDatix. We can also partner with systems. We're going after Barb Pelletrot's system right now, Common Spirit. We also can if you're personally interested in becoming an individual patient safety champion, we can put you through an orientation where we tell you about what WHO is doing, we explain the plan and invite you to be one of the activists that are going to be calling our legislators, meeting with government. You don't have to be a patient or family member. I mean, that special sauce again of anyone who cares about this and individually wants to put time into becoming a WHO patient safety champion, we can make that happen too. We do 3 or 4 so far orientation sessions a month for people that are interested in that. You're welcome. Thanks for the question. Any other comments? I think we're at time. Any other feedback you've got for us? Was this boring? Okay.
Fantastic. Well, thank you all so much for this opportunity.
Thanks for inviting us. Really enjoyed it. Stephen, I love this.
Enjoyed it.